Glaucoma is a silent but serious disease affecting nearly 80 million people worldwide. And if it's left untreated, it can lead to irreversible vision loss. Rising awareness about early diagnosis and effective management is crucial in preventing its progression. Today, we will discuss the case of a patient living with primary open angle glaucoma and dry eye syndrome, a common yet often overlooked side effect of long term glaucoma treatment. To guide us through this case, we are joined by Professor Mario de la Torre, Professor of Ophthalmology. Hello, Professor Mario de la Torre. So let's get started. Could you please introduce the patient's background?
Yes, of course. First of all, thank you for inviting me to this session. Yes, in the honor to the World Glaucoma Week, we are in the month of the glaucoma to make awareness all the people, patients and doctors about this silent thief of our vision. Concerning the patient, we have a 65-year-old male patient with a history of emetropia and presbyopia.
Okay.
His best corrected visual acuity was 1.0 in both eyes, meaning he sees well without distant correction. He was diagnosed with primary open-angle glaucoma 5 years ago, with initial intraocular pressure of 27 millimeters mercury in the right eye and 29 millimeters in the left eye.
That is high IOP on both eyes. So, what was his initial treatment?
I think they make the right decision. They use the prescribed latanoprost once daily at night and timolols twice daily. This combination is a standard for lowering intraocular pressure by increasing aqueous humor outflow and reducing aqueous production. There are many ways to treat the glaucoma initially. I suppose it's in the last 5 years, he began with one drop, then changed to another one. They added a second one. Sometimes you can use timolol, sometimes you can use the fixed combination. There are many ways. Anyway, here is his eye drop, 5 years continued.
Okay, that's interesting with these two eye drops treatment. So, how did his condition evolve?
Okay, we have the data that over time his intraocular pressure decreased, but in our examination remained elevated. We found 24 millimeters in the right eye and 25 millimeters in the left. And most important, not only this problem, but he started to experience significant dry eye symptoms during the treatment, including irritation, foreign body sensation, redness, and reduced visual acuity, especially in low light conditions. In summary, these symptoms affected his adherence to glaucoma treatment, causing discomfort and reducing his quality of life. This is a feature that we can see in a lot of patients. They have the right eye drops, by then left then, they don't use it properly, just because all those symptoms of dry eye can affect the adherence to the treatment. It could be a cause of the changing or the not achievement of the target pressure when he arrived to us.
And we know that patient's compliance is one of the main issue, of the follow-up.
Correct.
Take the treatment on eye drops. So that's a challenge we often hear about, and we know that patients struggling with side effects from their treatment. So, how the dry eye was diagnosed?
Yes, primarily it was a combination of clinical evaluation, as always, and the most important thing that right now we have advanced diagnostic tools like the CDAC platform. It's a system, computer-based system, all-in-one device that has all the features to help to the diagnostic to the doctor or the practitioner to do the diagnostic. Why? Because the system analyzes blinking patterns, tear meniscus height, lipid layer quality, and meibomian gland fusion using a high resolution imaging. And you can do it in 4 minutes.
Yes.
You can do it not touching the patient. No eye drops, no fluorescein. If you want, you can stain the patient, but in the normal procedure, it's a no contact examination. You don't need to have a topograph. You have one device exactly featured to do the examination in short time and very accurate. And after the examination, the results confirm evaporative dry eye, likely induced by chronic eye drop use.
Great. So, were there additional glaucoma assessments with additional glaucoma diagnostics done for this patient?
Yes, we did the routine examination. That means gonioscopy, visual field, examination of the optic nerve, measure of the ganglion cells, the fibers around the optic nerve, and etc. But very important, when we perform gonioscopy, show an open angle, but in 2 quadrants, a suspicion of plateau iris. Why we saw the double hem syndrome in 1K. This is very important. If you have more information, you have a better diagnostic.
For sure.
And we decide to get a more detailed view to use the biomicroscope ultrasound, the UVM, for the absolute, rather than anterior segment of CT. Why? Anterior segment is easy, fast, images are very nice, but the disadvantage is that we have only the vision to the, and it stops the vision in the iris, and we can see what's happening just behind. I mean, both are good methods, but they are complementary. The UVM provides better visualization of deeper structures, including the ciliary body and its processes.
Okay.
We can rule out another conditions, very easy, tumors in the ciliary body, cysts, signs of inflammation, etc., that we are not able using optical media. Using this biomicroscope, this is the UVM, we confirmed that the angle was open and suitable for laser treatment. We can also have some people say, okay, why do you use Mario UVM for that? You can use the poster, but the poster shows you if by the indentation, if you have an open angle by pressure. But about the mechanism of the angle, you have a better view of the angle with the UVM.
Okay. So as I understand, you had 2 issues to address. So first, the glaucoma management and also the dry eye relief. So how did you proceed, Mario?
Okay. First thing that we thought, okay, let's make the patient happy with his life, with quality of life.
Sure.
That is something very interesting. Our goal of doctors is to treat the pain, to treat all the conditions that affect the quality of life. In this case, it was not pain.
No.
But we said, okay, the patient has a dry eye.
Yeah.
We must do something for it. And we started with the treatment of intense pulsed light, the IPL therapy. What is the rationale of that, this study? We're targeting the periocular area in order to improve meibomian gland function. The protocol includes 4 sessions, spaced for 10 days. It could be 7 or 12, it all depends. And we combine with eyelid hygiene measurements. And the result was promising. His eye lubrication improved, irritation decreased, and he could tolerate glaucoma treatment better. But in this case, we have another idea about that.
Yes.
We solved the dry eye problem.
Okay. And that's great to hear for this patient. So what about his glaucoma for the treatment?
Sorry. Okay, as I told you, there are 2 options at the moment. We continue with eye drops or we change.
For sure.
And this is very, very sure. If we do always the same, we will get the same results.
For sure.
We decide to use the SLT treatment. Why? Given his poor adherence to eye drops and the need to have a more stable IOP control, we opted for the Selective Laser Trabeculoplasty, SLT. Why? This is a laser procedure, not destructive, targeting pigmented trabecular cells without causing structural damage. Is called the phototherapy for the trabecular meshwork. It enhances the aqueous humor drainage by inducing a mild inflammation response, and the immunological system of the patient can clean all those pigment melanin, that is the chromophobe that is acting the laser, and also at that moment can make some changes in the internal architecture and structure of the trabecular meshwork.
Good.
Cleaning all the channels, taking out all the metalloproteins and all the debris that is, and it clear out of the obstructions and promoting the tissue regeneration in that area. And this is great.
For sure.
It's smart, it's easy, and the results are very, very good. In fact, after the LIDA study, they conclude it could be, and really it is, a first-line treatment for glaucoma.
So as I understand, now you as a practitioner, you have the power, you manage now the glaucoma without the patients just putting the drops with the issue of compliance. So how was the SLT laser performed?
Very interesting, your assessment. Right now, with SLT, the treatment is in doctors or in the doctor's hand.
For sure. You manage.
Then you manage it. Some people is afraid, okay, I will miss the patient will go. No. The patient is always concerned about the intraocular pressure. But there is no problem with the compliance.
No.
There is no problem with the cost. Even there are a lot of studies that say that the cost of the eye drops in the year is immense. They are Canadian study, they are UK study in the United States. And okay, sometimes the people say it's a big amount in the very beginning, relative. Yes. Eye is not a business, you invest in your visual acuity. And then you ask me, how was the SLT performed? Oh, sure. We use the Tango Neo Reflex Laser, and we treat 360 degrees of the trabecular meshwork. It is very important to do that because some people make just the half of the treatment, as it's not as effective as doing it well. It's a not destructive procedure. You can go through the 360 degrees. This is important because the procedure was outpatient. It is well tolerated. And the most important thing, provide a sustained reduction of IOP. It reduced the patient dependence to the topical drops. Improving also, when it's the case that you need drops, his dry eye symptoms as well. It could be sufficient for a period of time. Normally, you can have 1 year, 2 years, 3 years, it all depends. And the advantage is you can repeat the treatment.
That's great.
Because it's not damaged. There is no damage in the trabecular meshwork. It's great.
So for the patient, you can retreat if you want to also manage the IOP pressure. So for the follow-up, what were the patient's results in the short term and also in the medium term?
Brilliant, very good. It was very happy with the results. At follow-up visits, his IOP was well controlled. We achieved the target IOP. That means you can plan the target in every single patient.
We know.
And we target in this patient 15 or 16, and we achieve it in time. And we continue to make the evaluation at the time. I mean, this is very important. his dry eye symptoms improve significantly with the IPL therapy that lead to better adherence in case he needs an extra medication, not only for glaucoma, it could be for another conditions. Overall, his visual quality or visual acuity as well, the comfort and the quality of the light was improved.
Yes, and that's very important, quality of life for the patients. In this case, really highlights the importance of a multidisciplinary approach, as I understand. So, what are your key takeaways?
Okay, absolutely. This case underscores 3 key points. First, integrating innovative therapies like IPL,
Yes.
you can enhance the patient comfort and adherence to glaucoma treatment. Second, SLT provides a safe and effective alternative for IOP control, reducing dependence of eye drops. Third, a comprehensive evaluation, including UVM, ensures tailored and safe treatment planning. By addressing both the primary disease, glaucoma, and the secondary complications, dry eye syndrome, we can provide something that is very, very important in medicine, a personalized care that improves both ocular health and quality of life. Having an holistic view how we can diagnose and treat the patient.
Yeah. And Mario, thank you so much for sharing your insights today. This discussion was really, really informative for me and also for our auditors.
I hope so. I hope that the message warning the people that glaucoma is the silent thief of our vision. That we are right now in the week of glaucoma, of the month of glaucoma, and taking in account that the glaucoma doesn't have symptoms for the patient. The patient don't notice that. It's in our hands, doctors or practitioners, to discover the condition in the patient.
Yes.
Using the anamnesis, using the right examinations, using all the tools that we have. You already mentioned it's a multimodal approach. And this is the trend in medicine. Don't have only one point of view, have a different range of devices. Right now, we have the technology in our hands. Some people say, okay, I can do it with a slit lamp, I can do it with something. No, if the technology is there, we can use it.
Yes.
We must use it.
Yes.
We must take advantage of all the developments in ophthalmology. Ophthalmology is one specialty that runs quick.
Yeah.
And if we have the possibility to do that, let's do it. And thank you for this opportunity, yes, to share a little bit some experience with that kind of patients. Thank you again.
Thank you, Mario. And definitely we will follow up your recommendations, being diagnosed first for glaucoma, and then do the 360, I will say, vision of how we can treat those patients. Thank you very much, Mario.